Good morning, everybody. Uh, we're going to start a session on Smart Eye Clinic. So basically, it is instruction course on how we can use a smartphone to take photos of anything, in the sense anterior, posterior segment, any microscopy device, microorganisms, retinoscopy, gonioscopy, and everything else that you're going to see. How you can make your own in your clinic. You can make your own device and take images. First of all, I would like to thank Dr. Rajiv sir, who doesn't need any introduction. And all we know that he is a tech savvy, and he has been very instrumental in all our KSOS, previous years KSOS, where it was done all online. Thank you, sir, for being us, for mentoring us. So, all of you, I welcome you to the Smart Eye Clinic.
Just want to briefly introduce our first speaker, Dr. Prithvi Chandrakanth. So he is currently a medical officer in Arvind Eye Hospital, Coimbatore, and he has won many awards for his numerous innovations using smartphone. And even IGO has started its own section on innovation just because of Prithvi's innovation on the trash to treasure red cam. Yeah, over to you, Prithvi.
So good morning, everybody. I'll be talking first about anterior segment photography with the intraocular lens and related anterior segment imaging devices. Uh, just to brief on what are the options we have. So slit lamp cameras are already there. The companies provide you with slit lamp cameras which take images with your mobile phone, with a smartphone, or a TV through the slit lamp. So all we need is a beam splitter which will split the image to two, one to the eyepiece of the observer and another one to the smartphone. Uh, just to briefly describe, here is one of my mentor, Dr. John Davis, showing you how you can take a freehand photography of an anterior segment. As you can see, you can keep the phone just 2 centimeter away from the eyepiece to get a proper round configuration of the anterior segment in the slit lamp. And then this is if you don't have an adapter or you don't have any adapters to attach, you can do the freehand technique of smartphone imaging. You can even take a photo of the QR code to see the video you can check over there. So after that comes the adapter. So there are many such adapters, 3D printed ones. When we can get it from Amazon, it costs only around 600 rupees or 500 rupees for the same. The only thing is you need to know how to fix it. So there is a smartphone attaching portion and then a slit lamp attaching portion. So keep the phone camera in between the attaching portion to the slit lamp, not keep it in the, yeah, you keep it in the center, and then you attach it to the slit lamp. Again, you need to keep the phone just 2 centimeters away from the actual eyepiece. So this way you can take images even without having any company camera, which could actually cost you more. So this only costs you around 500 rupees and you can just use it with your phone. As you can see, you can even take a undilated fundus examination can also be done with this. So next one, which is the most important one over here, is what if you don't have a slit lamp? You don't have a slit lamp, you don't have adapters with you. You can make your own device. You don't require slit lamp. You just need an intraocular lens. You can even borrow it from the OT if it falls down somewhere. You can just take it and you can make it into your own ASPI. So ASPI device basically. So let's just see why we need anti-segment imaging. So for documentation, follow-up, prognosis, to document all these things, for academic research purpose, and also mainly to counsel patients. So as we already seen, slit lamp cameras are there, but now the era of smartphones. So smartphone is very easy, it's portable, affordable, accessible. You can back up all these images, editing and sharing becomes easier. Teleophthalmology and rural health centers, you can use it very easily. As we have seen how we can use freehand photography and with adapters. The next thing we would want to see is what if we don't have a slit lamp? So that is the thing. because it's bulky, expensive. You cannot use, you take slit lamp everywhere. So the idea was, why not use a magnifying glass like an intraocular lens, which can be made by yourself and can be used in configuration with your smartphone. As you can see the principle, it's the IOL is just a biconvex lens. So any object kept inside the focal length, the first focal length will give you a magnified image. So this principle was taken, and then what we done is we took a chart paper. The chart paper was then cut into 10 centimeter to 1.5 centimeter. So so what we do is over here we'll attach a double-sided tape. So once you cut it out, make it into half, and you can fold it. So in between this, inside the portion, you're going to put the double-sided tape. Before that, we'll just mark a circle so that we make an opening for the intraocular lens to be kept. So that one you can use a paper puncher. So you get a paper puncher, you can just punch it out. So this is a double-sided tape which has been put. Once you put that, you can just cut it out with a paper puncher. It is all available in your clinic. So nothing extra to get to do this. So once you've done that, you can remove the double-sided tape. And then you can put a desired IOL. So I've been putting 15 to 20 to take anterior segment images. So 15 you will get a wider field. With 20 or 25 you get more focused image quality. Like over here, you can just attach it with a micropore or a sellotape, and now your phone camera has just turned into a macro lens, and it will take images of the eye. And this can be used in all type of phones, whether it be central or peripheral. As you can see, you just need to go a little close to the eye, and then you can take really good images. People won't even know whether it's been taken it from a slit lamp or just with an intraocular lens. So just imagine, with an intraocular lens, you can even take images of anterior segment. Here are a few of the images taken from ASPE. This is iris mass, giant papillae, neovascular glaucoma, corneal nerves, keratoplasty sutures, blue dot cataract with PSC, occlusio pupillae, pupillary membranes, hyperpion, ACIOL, posterior capsular rent, caterpillar hair, corneal foreign body, OSSN, bite spot. Another thing is you can even take videos of these pathologies. You can see phacoidonis is over here. And all of these can be taken without a slit lamp. So going to the next is the IOL scope and slim. So now what we have seen over here is we are using a 15 diopter lens or a 20 diopter or a 25 to capture anterior segment images. What if we use a more increased diopter lens, like a 30 diopter lens and 4 30 diopter lens? So that actually makes the next topic, that is the IOL scope. So as you can see, a microscope is the one which bridges macro and micro world, and it can be used for in ophthalmology for treatment, diagnosis, but it is basically largely restricted to labs. So what if we could make a device which was a point of care diagnostics device, which is portable, automated, which will reduce sample volume. And as we know, we have used this for smartphone for anterior segment. Why not use it to detect microorganisms too? So that is where IOL scope gave birth. And here is the way how we prepare it, is using a chart paper again. Punch it with the puncher, so make a small hole, and then you can use 30 diopter lens, 4 30 diopter lens, and paste it with just a liquid adhesive like Fevicol. So you need 4 30 diopter lens to be kept one upon the other. You need to be sure that it is properly placed on each other. So once you do this, you're increasing the diopter of the lens, and by this, once it's ready, you can put it on the phone. Yeah, and then you'll require a illumination device. So you can use it. You can use a smartphone or a torch or a direct sunlight. Here is a demonstration on torch. You keep the slide whichever you want to image, and this way you can take images of microorganisms. A few examples which are coming up. This is a rhizopus mount taken using the slit lamp, the phone, smartphone, and the IOL scope. The fungal hyphae is Estrus ovis larvae, caterpillar hair. These are all taken in the OPD setup. Don't need any extra device. Need a small phone and the IOL scope, and you can start diagnosing all these images. So what happened is, my dear friend Dr. Prasanna, he had called me during the COVID time. So it's a very crucial time where COVID-19 and mucormycosis was in a spread. And there are a lot of literature on mucormycosis and also ROCM, that is so we needed debridement and the extensive debridement in paranasal sinuses. What happens is the ENT surgeon needs to find out whether the debrided area has the fungus or not. So he called me up, he asked me if my IOL scope can do this, can it detect the fungal hyphae. So I said, why not, we could try that. So during the surgery, live surgery, he gave a specimen from the paranasal sinuses, and we started cutting section and started checking for hyphae, and you can see over here such a big hyphae material. And just to prove that this was a fungal hyphae, we had taken it to the microbiology lab and checked it, and it was similar. You can see how clearly it could be seen. So we described this, and then the next was slim. So how intraocular lens, the IOL scope, can be used on a slit lamp, like on our own slit lamp, to convert it into a point of care diagnostic thing. So as we know, we do this, we do scraping, and if we have a microbiology lab in our institute, it's well and good, because you can go and check. And I don't know how many people actually have a microscope to actually check the fungal hyphae in their own clinics. But I know for a fact that it lacks in most of the clinics. So why not use IOL scope for the same? So we need an adapter, a torch, an IOL scope, which we have already made. And over here we'll show you how you can attach it. So either you can attach it by removing the illumination part, or you can even put it on top, if on top of the illumination part, if there is a small hook. So the phone adapter which we saw for the smartphone slit lamp photography, the same adapter we are using here, but the arrangement of the smartphone is reversed. So usually you keep it towards the connecting adapter, right? So we keep it reverse. This is an attachment to the slit lamp. It will move with the joystick and this thing, and this is the attachment of the smartphone to the slit lamp. Now what you need to do is, you can either keep a illumination torch from a phone or a handheld torch. You can take corneal scrapings and see for fungus right there at the OPD itself. And with the attachment of the slit lamp, it becomes more easier. It doesn't shake. The phone doesn't shake. You can use it to go around the whole field of sample. So here there's a demo showing the same. And then you can just check for fungal hyphae. So basically now we are doing it for fungal hyphae. The one for bacteria and viruses, we have not yet refined it. So here you can see, you can even put it, you don't have to remove the illumination part, you can just keep it on top of this thing. And recently in All India DreamCon in Mumbai, we presented a physical poster which won an award. And this is a first study, it's called FIRST Fungal Hyphae Detection Study, where 10 10 such fungus were diagnosed for their morphology, the clarity of hyphae. As you can see over here, Aspergillus. This is an actual microscope. This is an IOL scope. This is Alternaria in microscope, and this is from IOL scope. Bipolaris microscope and IOL scope. And here mucormycosis, in that. And we compared the quality of images, and we found that the quality was good enough to understand if there is a hyphae or not. So it can be, we can detect fungus, but not every time can we actually identify the actual species of the fungus. And then we also used it to diagnose parasites like Estrus ovis larvae and also Demodex. With this, I would like to say that with an IOL, implanting it in cataract surgery, with using it in extraocular ways, we can use it for imaging, like in anti-segment imaging and for microscopy. For the next talk, I would like Dr. Shishir to come here. He'll be talking about the Trans Treasure Red Cam and Aspigonio. So, Dr. Shishir is a consultant vitreoretinal surgeon in eye microsurgery and laser center in Tiruvalla. He has done his former MS ophthalmology in Vellore, and he's been a VRS fellow in Arvind Eye Hospital, Coimbatore. He has keen interest in publishing articles, and he has more than 20 to 30 published articles in his name in peer-reviewed PubMed Index journals. I'd like to invite him to give his talk. This one only. Yeah. Thank you, everybody.
Yeah, great talk, Prithvi. So I'll be just expanding the same use of smartphone into other forms of imaging. So no financial interest again. So we know that the smartphone, there's been a big revolution, and it's been used for almost all types of ocular imaging, right from the anterior to the posterior segment. And this is like probably will be the new way to go about it. So I'll expand the use of the ASPE, what Prithvi just described, to gonio imaging also. So we know glaucoma, most second common cause of blindness, with large population in India being affected from it. And we have open angle glaucoma being same as narrow angle disease, which is equally prevalent in India. So when you make a diagnosis of open angle glaucoma, how do you need to do a gonioscopy to actually see that the angles are open, following which only you can make a diagnosis of open angle glaucoma. So visualizing the anterior chamber angle is very integral for the screening. So the previous imaging techniques have been taken utilizing the slit lamp. So smartphone has been described for gonio imaging. So where two previous small innovative techniques were published in the Journal of Glaucoma, utilizing the smartphone, but they were an unaided technique. They did not use any macro lens. And the patient needed to be in a supine position to kind of get these images. So this first image here, which shows that the patient is in supine position, and using a gonio mirror, you just directly use a smartphone and click the angle images, and you could get a little bit of a wide field view, but not a very clear view to actually grade or image the angle very clearly. The other technique utilized an iPhone 11 Pro Max, and then utilizing that, you could get good images of the angle, and along with that, you could, if there was a second observer with a retinoscope, you can throw a slit light and you can even get slit images of the angle. You could actually grade it also. So Prithvi has already described the ASPE, and so the aim of expanding the use of ASPE to gonioscope was to take low cost device to take pictures of the anterior chamber angle using an IOL, and also to highlight that the intraocular lens can be used as a macro lens. So the material required, again, ASPE, then you definitely require gonio mirrors. Use slit lamp and retinoscope are optional. That's only if you want to take slit images. You, however, require IOL powers of 6 diopter, 8 diopter, or 10 diopter. You cannot take more power of IOL, like what Prithvi described for his ASP. 15 or 20, you cannot take it because you cannot take images with that. You need either 6D, 8D, or 10D IOLs. And obviously, gonio mirror, anyone will do. A contact technique like a 2-mirror gonio mirror is slightly better. But if you also have a 4-mirror or a 6-mirror, you can take images with these. So methodology, we actually did gonio imaging on 33 eyes of 20 patients, and it was a routine slit lamp examination followed with putting topical anesthesia, checking the intraocular pressure, and then you can place the gonio mirror and you can image them using the ASPE. So you can do it either in the sitting position with the chin of the patient on the slit lamp, or you can, even if the slit lamp is not there, when you go for your glaucoma screening or they send you for screening camps, before you want to dilate the patient, you can just make them sit and then you can put the gonio mirror and you can image the angle. Or if you can even do it in the supine position. So how to acquire the image? So the phone needs to be on, with the flash should be on, and it should be on the video mode. And then if you utilizing a 6 diopter IOL, you can take a good image with, and the distance between the gonio mirror and the IOL is quite significant. So you don't need to go very close with the phone, but if you're using a higher power IOL like 8D or 10D, then you need to go really close to the gonio mirror to acquire a good and a clear image. So these are some of the images which we obtained using, the first image is with the 6 diopter, the second image with the 8 diopter, and the final image is with the 10 diopter. So little more wider field of view with the 6 diopter and a little more close-up view with the 10 diopter. And you can get these different images with the single mirror lens, a dual mirror lens, or a 4-mirror lens. These are the images which you get. So a contact technique slightly more better than the 4-mirror lens. So these are some of the other images which we got, and then it can be magnified because of the zoom of the phone. So if you get even a wider picture, you can magnify it and see the angle structures very, very clearly. So this second image is that of a post-trabeculectomy patient. You can see the ostium and also the PI which is being made, and get it very clearly with the gonio. And this final picture is that of silicone oil, emulsified silicone oil in the superior angle. We could even get slit images. The only thing with slit images is you need a second observer. So, or you have to do it on a slit lamp. So placing the gonio mirror and then putting the ASPE, getting the image, and then you need a second observer to kind of throw a retinoscopic reflex light onto the gonio mirror so that you can get a slit image of the angle. So here grading of your angle can also be done using this technique. So the advantages, it's good resolution, any gonio mirror can be used, it's quick, inexpensive screening tool, utilized especially in secondary centers or in peripheral centers or during your CAM screening, and it's good for resident training and education. You can send for a second opinion, whether to a senior person to see the angles. So few limitations, a small learning curve for beginners, when you move your smartphone, and you cannot use an IOL of more than 10 diopters. So, and sometimes not everybody has a iPhone with a peripheral camera. Some of them will have a central camera. So then your maneuverability is a little difficult because it's obstructed by the nasal bridge of the patient. So a little difficulty with the a central camera, but if you have a peripheral camera, it's good. If you put a 6 diopter lens in a phone with a central camera, then the problem is sorted out. So you really need to have a 6 diopter IOL to get like good and wide field images. So I'll go on to the next one, which is the trash to treasure red cam. So now we know that we have a lot of devices for fundus imaging. So we have the fundus cameras, mydriatic and non-mydriatic. We have the handheld fundus cameras manufactured by different companies. And we also, now we have smartphone based fundus imaging. So initially, smartphone-based fundus imaging was described by Lord, and he used the video mode of the phone to continuously image the posterior segment, and then he used to extract frames from it. So it's particularly useful in low and middle income countries where you cannot really buy high-cost posterior segment imaging camera. So now smartphone based imaging is more advanced now and there are specific softwares available to improve the quality of the image. So what is the principle? The principle is same like an indirect ophthalmoscopy. Here, instead of your eye, it's being replaced by a smartphone. So using that same principle, your smartphone captures the image in video mode or in photo mode, and then you can visualize it later. So a lot of my colleagues, they have been doing this smartphone based imaging, but however they are not utilizing any adapters, or they're directly putting the 20D lens and then using the smartphone in their hand, they're trying to capture the video. So a lot of them are doing because they don't have the imaging devices, and some of them are even visiting secondary and peripheral centers where they're utilizing this sort of a technique to get images. So we have now smartphone made red cams available. So this first one was the DY red cam by Dr. Biju Raju and John Davis and group. So they developed that, but it was a little complex and it did not require a slit lamp to use. Whereas the commercially available ones, the Me red cam by Dr. Ashish Sharma and the JS by Dr. Jayatra, they're commercially available and it's a slit lamp based adapter you have to use to image. The other ones by different companies, Welch-Allyn, they have one which gives you a 25-degree field of view. There is one by DI that is 200-degree field of view. And then there is another one by Peak Retina which will give you approximately 40 to 50-degree field of view. The VOC also has developed one which will give you around 45 to 56-degree field of view. So, but for that you require an iPhone SE or an iPhone 5 which is compatible with their camera. The device, and then using that you can get pretty good images. They also have their app, the VOC InView app. So if you that will help you click pictures by once you automatically focus, the device will automatically click the picture with the help of the app. So Dr. John Davis has developed one using 3D printing technology. He has developed one which is called the John Das Pocket Foldable Fundoscope. So using this, it's a pocket thing and 3D printed. You can unfold it, put in your 20D lens, and then you can get good images of the smartphone. It's patent pending, and I think it's 800 for one. So it's a low cost, ultra portable camera, and it acts as a case for the 20D lens also. So the next, what Prithvi has developed is the T3 red cam, the trash to treasure red cam, which is a simple, affordable, do it yourself, and it's wireless. So this is a very small video on how to make it. You need a sanitizer bottle which is used, and then you can cut out using a scalpel a holder to place your 20D lens. Yeah, so once you have removed the tip, you can just fold in the edges and then you can put your 20D lens. Yeah, so now it's technically ready to use. You can put the adapter it's available on Amazon. That's a universal smartphone adapter. You can just attach it and then attach your phone to it, and then you can put a black paper to prevent the reflection of light. So then now this device is ready. The smartphone adapter is available in Amazon for 490 rupees. This is the link. And so again, the principle is the same, acts like your indirect ophthalmoscopy. Only thing, instead of your eye, it's now your smartphone which is going to take the images. So how to acquire the image? Video mode of this with flash on, and then dilatation in a dark room preferred, supine or sitting position. You support the device with one hand with the index finger, and with the other hand you have to open the pupil. Open the lids of the patient so that you can get a good, with the dilated pupil, and get a good image using your smartphone. So peripheral images you can get when you ask them to look up and down, right or left, and the image, what is recorded on the smartphone will be like how you see, inverted and laterally reversed. So multiple apps are available like the Hope Scope and the Alman Indirect app, which will help you remove the artifacts and re-invert these images. So this is the T3R in action, specifically useful for DR screening in multiple peripheral centers, and even for ROP it has been used, and you can get pretty good and clear images of the posterior segment. So there's a small learning curve, and the smartphone flash should be coaxial with the camera, otherwise you won't get a good images. And the magnification depends on the type of lens used. So if you're using a 20D lens, it'll be 56 degrees, and that's ideally the best lens, because the more, if you use 2.2 or 22 diopter, then you have more of reflexes coming in. So this has been used for the diabetic screening and found to be quite sensitive and 100% specific. So again, when you use for DR screening, and you can get pretty good images, and you can almost diagnose the disease there itself during the screening. So smartphone has definitely revolutionized, and smartphone fundoscopy, it has been used for diabetic retinopathy, ROP, glaucoma, even in pediatrics, for teaching definitely, and even for during emergency medicine, when you're called to the emergency to see for papilledema, you can use this T3R RedCam, or you can use the smartphone based fundus imaging. So the advantages, both photos and videos could be obtained, and you don't need an expert person to utilize it. So improves the cost effectiveness of screening, and is affordable, portable, and for telemedicine and teaching. In ICUs, could be used for patients who are supine and you want to see the fundus, can definitely be used. So small disadvantages, small learning curve for beginners. Again, there can be slight glare, and if you have cataract and media glare, then obviously the image quality won't be so good. So there has always been a question of smartphone light safety. So ISO has graded the safety profile for these ophthalmic instruments. So they say that 1 minute retinal exposure is for these current smartphones, they don't cause any thermal or any photochemical damage. But now we have latest models of phones coming up which are 20 times more power. So these should be analyzed before you actually use it for retinal imaging. So to conclude, it's ASPI Gonio, very effective for screening, imaging, and documentation. You can grade and image the anterior chamber angle. And for fundus imaging, the T3R is a frugal and easy do-it-yourself smartphone imaging technique. And the risk for photo damage using the current phones and current flashlights is extremely less. Another advantage of smartphone, you can get a lot of literature out of it. So thank you.
No, you finish this.
Finish that. Yeah. Okay. So I have one more small, very small talk. You can put on the screen. Yeah. Okay. So smartphone assisted refraction, particularly useful for those who are learning refraction, beginners, first year residents, and even for optometry students. So again, no financial interest. So retinoscopy is quite an objective refraction technique, and it's very important for assessing refractive errors, especially for children and even adults, for prescribing a good power of the spectacles. And we do have excellent literature and animated videos available for the refraction, but when you teach, you simultaneously cannot observe the reflex, and even the observer or the mentor cannot really tell what type of a reflex you have obtained. You cannot observe it simultaneously. So that's the problem with the refraction. When you teach, you observe some reflex, but when you tell, they may feel that it's different. So in the previous techniques have been used where they use a teaching attachment onto the retinoscopy. So this was one by Welch Allen, where they utilized another tube, attached it to the retinoscopy, and then one observer will see through the pinhole and the other observer will see through the side scope. So this is another one where they put in a camera, connected it to a TV, and then you could observe the reflexes directly on the television. The Hein have developed a prototype video retinoscope where you use that to get the retinoscopic reflexes from the patient, and whatever the reflex you get is imaged onto the screen there. So learning and teaching is better when both the mentor and observer are able to see and appreciate the retinoscopic reflex. So we describe this technique, the gimbal scope. So what is gimbal? It's any device for keeping an instrument such as a compass horizontally in a moving vessel or aircraft. So that was the word gimbal which we got from, and it's commercially available on Amazon, this gimbal, for basically imaging cameras or even smartphones. So we developed the gimbal scope utilizing the smartphone adapter, the retinoscope, and then putting the adapter, attaching the adapter onto the retinoscope, we could directly do a retinoscopy. So here again, the principle is the same. Instead of your eye, the smartphone is the one which is capturing the reflexes. So this, once you do it on patients, the retinoscope reflex could be observed by the mentor as well as a trainee student or the optometrist who's standing along with you, and they could both appreciate the reflexes when you use a smartphone, because the smartphone is the one which is going to record these reflexes. So the advantage is easy assembly, clear retinoscopic reflexes, and this is a zoom tool for magnification. It's better understanding of phenomenon by these beginners. So video recording is important, can appreciate the reflexes and see it later, and it's a convenient, inexpensive tool. So it's a teaching tool for medical students, residents, and optometrists, and can be used in primary or secondary centers. Yeah. Okay, thank you.
Thank you, Dr. Shishir.
Yeah.
I invite Dr. Atul Putlat to give his talk. He's a retina fellow right now in Arvind Eye Hospital, Madurai.
Using that.
He has done his PG in AIMS Rishikesh, and he has enough and more awards on innovation, and he's had more than 20 index publications in peer-reviewed journals. He also is a part of the nodal team of COVID-19 associated mucormycosis while he was in AIMS Rishikesh, Uttarakhand. So I would like Atul to give his talk on cobalt blue smartphone photography.
Thank you, Prithvi. Good morning to all the audience here. So I'll be brief. Basically, I'll be talking about blue light photography, how you can use your smartphone to help in blue light photography. So I'll be talking about three things: the C Blue adapter, blue patch, and Scooby Doo. These three things help us in blue light photography. So as we know, we take blue light photographs after staining the cornea with fluorescein stain, and we usually have access to a photo slit lamp. Then we make the patient sit on the photo slit lamp and we switch on the blue light and we take the photo. But what if you don't have a photo slit lamp available? So when there are problems, a need of innovation arise. So like in emergency in ocular trauma, when you don't have a slit lamp, or in chronic bedridden patients in ICU, or for example infants where you have to photo document their fluorescein stained corneas, or in remote eye cams for example, how can you photo document these? So we thought to ourselves, what if? What if we can develop an attachment for smartphone? Because everyone has a smartphone nowadays, but it has to be low cost. It should be available and useful to anyone, health assistant, doctors, and MLOPs alike. It should be portable, pocket-sized, and easy in handling. At the same time, it should give good quality images, stain positive or negative, and should be reproducible. So, with this idea in mind, we opened up the old slit lamp and we did some research on the cobalt blue filter that was in situ. Then we developed the principle that white light from any flashlight of any smartphone, if we put a cobalt blue filter in front of it, it can filter out the other spectrum and we can get the blue light in the range 450 to 490 nanometers, which can help us in photography. So we developed the first prototype. It was called the C Blue adapter. So as you can see here, this is made using a commercially available adapter which was modified. C Blue stands for Cobalt Blue Light Unit. So these are the parts of the C Blue adapter. It has a blue filter lens, an hand screw, and the part that attaches onto the smartphone. So we captured good quality cobalt blue images of various corneal pathologies, but it had limitations. It was not universal. As you could see, it was bulky. And we had to reduce a further cost, and so the search continued for a better version. So we were in search for a universal design. So this search led us through a lot of R&D. We developed, changed the designs, worked on the illumination. Then finally we arrived on something called as a patch. So first we developed a sea blue clip, which was, it would be clipped onto the flashlight. Then we developed the line light or also the ring light. But these two used external light illumination, not the smartphone's flashlight. But these were not enough. We were not happy. Then finally we arrived at the blue patch. As you can see how tiny it is, but powerful at the same time. So what is blue patch? So blue patch is basically made from gum paper. It uses the same principle as a sea blue adapter, and it is sticky on one side. You can peel it off and stick it onto your smartphones. It is machine cut into precise circles. So I'll just a small video on how it is done. So we will stain the cornea with fluorescein stain. Then you can use any smartphone, iPhone, Android alike, as long as you have a good camera. You can peel off the blue patch from the strip and you can stick it onto the flashlight of your smartphone. Once it is adequately stuck, the phone is ready for blue light photography. So we prefer dark room. Any camera app can be used. We have used open camera in this, and we can get a good focus and we can get the fluorescein stained corneal images of the patient. So let us look at some sample images obtained with blue patch. This is an epithelial defect, and this is another case of exposure keratitis. Then central infiltrate was photographed, and punctate keratitis in chronic dry eye. These are just a few examples. So we are working on this further. The future directions, this point, we are working on to make this available for teleophthalmology. And with the way AI is developing, it can be equipped with AI so that the device can self-diagnose and help in further teleophthalmology and consultations. Now we have already developed a red-free filter, which can help in photographing retinal nerve fiber layer defects in glaucoma. We are still working on that, but we are able to photograph with those. And this is Scooby-Doo, smartphone co-aided cobalt blue light photography, do-it-yourself concept, similar to ASPI, which Dr. Prithvi was showing earlier. Basically what we use is, we use a commercially available blue filter glass or a plastic piece, which can be modified and cut into circles and coupled with the same intraocular lens, which was used in ASPI. And it can be used both with a central camera smartphone or a peripheral camera smartphone. And as you can see how it's being made, and these are some of the images which were captured with the do-it-yourself Scooby-Doo technique. So this is just one application of blue light photography and smartphones in ophthalmology. So thank you for your patient listening.
Thank you, Dr. Atul. Now I would like to invite Dr. Prasanna Venkatesh Ramesh. He is MS Ophthalmology Gold Medalist, finished his glaucoma fellow under Dr. Satyan, and he has a degree of FAICO glaucoma, FICO glaucoma, and is medical director of Mahatma Eye Hospital Private Limited in Trichy. He has numerous, around 100 public articles published in his name, and he is also an executive member in TNOA. Also has editor board of TNOA journal. I would like to invite Dr. Prasanna to give his talk on smartphone AI.
Yeah, thank you, Prithvi and Rajiv sir and the whole KSOS team for giving me this opportunity. So I'd like to start my presentation with a small demo of our innovation. So can we have the display, please? Yeah. So we like to show one particular innovation of ours, the augmented reality that we have recently innovated, and we have trying to revolutionize teaching, counseling, as well as surgical simulations. So yeah, can we have the screen? To add on to the smartphone clinic discussion, so we wanted to see how we can actually extrapolate more amount of technological evidences and use it maximum to smart teaching, smart counseling, as well as for smart simulative models. So one such thing I would see whether if it's working, or else I'll go for my presentation, which I have it as a backup. Yeah, it's done. So can you just demonstrate the models, Tenzing? Yeah. You can see that many of us would have seen the Iron Man movie in Marvel, the Tony Stark, or the Iron Man, which we all see. Now you can see my friend here demonstrating the cavernous sinus. Many of us used to just cognitively mug up the anatomy of cavernous sinus. We never used to see how the transverse vein, the sigmoid veins all come and insert with each other. But now you see, my friend here seems to be demonstrating through thin air, but he is actually holding the patient's cavernous sinus and demonstrating it in real 3 dimensions with the hand-eye coordination. This, my dear friends, is what we believe will be the future of pedagogy. We don't need to really mug up the concepts, rather we can actually teach students what things are really are. Can we have the eyeball model, Tenzing, now? Yeah. Let's move to the eyeball model. Or the circle of Willis, yeah, we'll show the circle of Willis. Circle of Willis is, my dear friends, is again an undissectable structure. We never dissect the circle of Willis in our anatomy teaching. I remember my days where I used to draw a pentagon, then draw a horizontal line, a vertical line. A lot of mugging up was there. But now this is a 3-dimensional structure which we sat with our anatomy books, drew the structure in 3D, and then we are trying to reconstruct it according to the patient's own case sheet. You can see that every anatomical part is there as 3D itself. You can rotate it. There is no blind spot as such. You get the structures as and when it is. And this is augmented reality, my dear friends, not virtual reality, because in virtual reality, the background is actually completely dark. In augmented reality, what we are seeing in the screen is what actually the person is seeing through his eyes. So this is next level cutting edge technology for surgical simulations as well. Can we have the eyeball? Yeah. So we all have anatomy classes. We have a huge difficulty to explain to undergraduates, postgraduates. In our models, we have used real fundus images. You can see the real optic disc, the macula. We have given a cross-sectional opening so that we can go into the eye, see the ciliary body, the lens, the zonules. And can we have an angle examination of the patient done now? Yeah. So this is like in telemedicine, we are trying to work on an EMR as well, where you can see that my dear friend is examining the angle structure. Not only the angle is seen in one particular frame of choice, it can be seen in any view. Can we have the side angle view and the magnified view so that the electron microscopic view is also shown? Yes. So now Mr. Tenzing here, who is also my research assistant, is examining, see what is an angle recess. See, you can see the beautiful angle recess here, a scleral spur here, and all the electron microscopic band view of the trabecular meshwork. Yes. Can we have the simulation of the direct ophthalmoscope? Yeah. Yeah, Tenzing, we just have a small glitch. Yeah, we are back. So this is the whole brain, the whole neural anatomy that we have also re-engineered or reconstructed. My friend here is actually, can you have the hand stationary like a direct ophthalmoscope? Yeah. Move into the eye. Yeah. So this is a direct ophthalmoscopy simulator where you can move towards the patient's cornea. You can come back again. Yeah, you can go back. Yeah, nicely go back. Yeah. Now again go back into the eye. So these are some simple simulators that on day 1 of the curriculum, the students can actually be taught, because it is hand-eye coordination. They see in reality what things are. Again, you can go back. Yeah, so this is the brain structure along with the whole eye that we have actually done, and we are trying to go back to even more. You can see the whole extraocular muscles. You can walk into the brain, show the dorsal pathway of all the nuclei. So the whole neuroanatomy is something that we have reconstructed, and this has been our baby for 5 years from now, and we have recently launched it in the market. So I'll just have my presentation now for the next 2 minutes to just summarize. So can I have the slides? So this, my dear friends, is augmented reality. We have virtual reality where the complete blackout is there and the opponent can never see what we are seeing. But with this technology, what we are trying to address is a simulative way of learning. What we see, sometimes our students may not actually see. Are you seeing the gonioscopy structures, or this is how the direct ophthalmoscopy has to be done? but they never tend to see exactly what we see through our eyes. But with this simulator that we have innovated, not only teaching, counseling, and for simulative models, we are trying to also inculcate into EMR as well as into telemedicine, so that even patient examination can be done as we are using real-time patient images. So how did this journey all start? Is the next few 2 or 3 minutes, I'll just take you through the mandatory slides, or take you through the pathway or cognitive way of how we actually innovated this. So my friend will be coming to each one of you. You can personally experience the touch sensation, what he is actually seeing through his eyes. Tenzing, you can just show the innovation to all if time permits. Do you have a converter? A HDMI converter? Yes. So what Iron Man or Tony Stark, many of us would have seen this, even in the Jeans movie, we would have seen in 1990 Shankar, which was not thought to be reality. It was all thought to be science fiction. Is no more science fiction, my dear friends. We have innovated it in the field of ophthalmology, and my dear friend will be coming and you can all experience that in the place where you are sitting itself. We call it the 4D metaverse, which is a patent protected technology of ours, and we have a series of 6 smart innovations. We started with animations. What is a normal angle structure? What is a peripheral anterior synechiae? My journey started with animative learning. How can we make learning more catchy or more easier for the neophyte? We started making animative videos and then took them into real-time scenarios like an iris process and a peripheral anterior synechiae, as you can see here. Then we started making videos on short videos, 10 seconds, with less is more concept on why do we do a YAG PA? Because of the cause and effect. The cause is the pupillary block here, and the effect is the angle closure that happens here. So we wanted to make less is more in a single minute. Can we really give a concept which is very complex as glaucoma? This is one of my own videos where you can see the fundus of a patient. We just marked the cup and showed that the cup disc ratio is altered with increased vertical cupping. Then the video was slightly zoomed, and then you can see that the inferior notch is marked. Then we can go even more zoomed, and we can show the unspecific, the bionetting sign, and then the basic signs is the ISNT rule. How is it actually breached? You can see that the inferior is lesser than the superior, coming back to the RNFL. And always as a glaucomatologist, we like to correlate the structure with the function. Have the same patient's visual field, and then have the OCT superimposed on the fundus and show how the RNFL defect is there, again in the OCT as well, followed by a mild ganglion cell layer, inner plexiform layer, thickness reduction. So this is a single minute video where we thought of taking on the challenge of making all complex pathologies in a single minute. As you can see, this is my YouTube channel which goes under my name. Many complex pathologies are delivered in a single minute for smart learning. So be it anything such as you can see here, an ALT or an SLT, the spot sizes are lesser in ALT, it's higher in an SLT. In oppositional angle closure, the dying out of ALPI, as you can see in this patient, an oppositional angle is relieved by an ALPI which is done in the periphery, causing the iris to pull back. The same can be shown in a front-down angle view where 24 spots are placed in 360 degrees. The same can also be shown in a gonioscopic view where the spot is delivered, and you can see how the iris is being pulled away from the angle, relieving the opposition. Even basic concepts like removing the lens in a cataractous patient, you can see how the anterior chamber is deepening. You can see the fate of iris, how it falls back when the iris or the lens is removed. The fate of the ciliary body, how it slightly falls back when the cataractus lens is removed and an IOL is placed. A simple falling back of the scleral spur. This gives us good understanding about the primary angle closure glaucoma concepts or the release of the posterior, the peripheral anterior synechiae after cataract extraction. Then we started creating these models in 3D because we felt 3D animation is the way forward. Cavernous sinus, circle of Willis, the eye structures as a whole with real images. The one with our USP model of 3D was we went with real images, real fundus, real gonioscopic pictures as much as possible to have the photoreal effect which my friend is trying to come to your place and show. We also launched it in the Android platform. Nowadays the phones are equipped with augmented reality. You just need to download this app and you can just access it through buttons. You can click the anatomy and you can have a complete tunneling of full way in which your choice, how you want to go into the eye. You can choose anterior segment, go into the anterior segment. You can then choose the angle, you can go into the angle. This is like a button system, which was a very prototype model that we developed for the Android systems. And then you can see even that goes to the posterior segment as well. For want of time, I'll rush through and finish within a minute or so. You can see that we started using many pathologies. We started adding on autofluorescence, infrared, and the pathologies list kept on increasing. Flecked retina, fibrovascular band, retinitis pigmentosa. These are all our own patient data. Started collecting like an atlas. Any retinal pathology, any angle pathology, we started collecting. We had a Windows version of it, not only in the smartphone. The Windows version is also available. Then we also launched this in the Apple as well. You can see that a simple phone is actually showing the same model. The technology that we used to take a selfie with the spectacle glass or with the hat, the same technology we use to bring it into ophthalmology for teaching. We don't need to really know where the structures are. They can see it on day one and understand the anatomy as and when it is, and they can know it in real time. So this is again a phone display where you can see the structures that you are seeing in 4 dimensions can also be seen in your smart clinic and also be diagnosed, or even the patients can be counseled. This is again one of my glaucoma patients with a splinter hemorrhage, another patient with an RNFL defect that you can see beautifully in 3D augmented reality. Then this is the 4D holograms that we recently displayed. I'm just skipping it. It seems as if you're moving through thin air, but it is actually you are touching, you're feeling. You can actually move through simulations, and there are so many implications. We can learn SACS, phaco, surgeries through this augmented reality technology. We have also recently innovated a MIGS simulator, which recently won the best poster award in the recently concluded Glaucoma Society of India. And then you can see that we can use many OCT filters. Practicing a hydrodissection and hydrodelineation can be done with this technology. And this is my daughter here. The future generation children are very much equipped to this. I think this is going to be the future where it's going to be coming into the market. We are also 3D printing these structures. We are going back to the basics. We are using this technology to reinvent 3D printing for basic sciences. Like an automobile engineer, can we learn things like this? And we have also done this in the iPhone as well. The beauty about an iPhone is we have used subtractive learning. The structures that we don't want, we are actually removing it, and it is more like a virtual dissection. As you can see, the structures that we don't want, it's all subtractively removed. And I think this, my dear friends, will be the future in ophthalmic teaching and counseling. We call it the ophthalmic metaverse. And with that, I'll just stop for want of time. I'll just give you the last slide. And this is my team, headed by me. We are a team of 6 people, ophthalmologist and optometrist at Mahatma Hospital, Trichy. You can take a screenshot of this, my dear friends. These are the 6 innovations of ours, open access, currently readily available in the market. You can feel free to use it and share your feedback. And out of the 6, 5 are published in the innovation section in Indian Journal of Ophthalmology. One is currently yet to be published, which is the recent one. And we make a lot of images. The DreamCon image was made by us, which you would have all seen on the program book. And we make a lot of images. Imaging is what we specialize in, and I'm also a glaucoma specialist, so I have an inclination to glaucoma as well. Thank you once again, Prithvi and the entire KSOS team, for giving me this time to showcase on the smart innovations that we are currently doing. Thank you once again.
Thank you, Dr. Prasanna. I would like Rajiv sir to give away a certificate and a memento to our guest faculty. I would also like Rajiv sir to give some comments on the same.
we are having the next session at 1 o'clock. So with one word I'll say, smart guys did a smart job today.